It's obstetric and gynecology made easy. Today we are going to talk about antiseptic and antibiotic prophylaxis in cesarean section, according to American College, Royal College, and WHO. We will start with skin antiseptic. Antiseptic use for skin according to American College, Royal College, and WHO. The recommendations are similar. Chlorhexidine gluconate. Chlorhexidine gluconate is the preferred antiseptic. It's recommended due to its superior effectiveness in reducing the microbial load on the skin by its lasting antimicrobial activity. Alcohol-based solution. The combination of chlorhexidine with alcohol is often suggested as it provides rapid and long-lasting antimicrobial activity. Povidone iodine. Alternative antiseptic. It can used especially in cases where chlorhexidine is contraindicated, like allergy. Alcohol-based formulations. These are also available and recommended for improved efficacy. The antiseptic should be applied thoroughly to the surgical area. Apply the solution in a circular motion, starting at the incision site and moving outward. The antiseptic should be allowed to dry completely before making the incision. The recommended duration usually around 3 minutes for chlorhexidine with alcohol. This ensures maximum effectiveness in reducing the risk of infections. Vaginal antiseptic. All three organizations, American College, Royal College, and WHO, recommend selective use of vaginal antiseptic preparation rather than routine use. They target higher risk situations such as prolonged labor and ruptured membranes. American College tends to favor povidone iodine. Chlorhexidine is an alternative. Royal College often prefers chlorhexidine, povidone iodine as an alternative, and WHO does not strongly endorse one over the other. The choice of antiseptic should be based on local protocols, patient condition, and available resources. All guidelines suggest the use of a sterile sponge or swab soaked in the chosen antiseptic to clean the vaginal canal with circular motion, ensuring through coverage of the vaginal walls. The antiseptic should be allowed to air dry for 2 to 3 minutes before proceeding with surgery. Now we are going to talk about antibiotic prophylaxis according to guidelines from RCOG, American College Practice Bulletin, and WHO guideline for the prevention of surgical site infections. This is a comparison between Royal College, American College, and WHO. We'll start with time of antibiotic administration. All of them recommend the time of antibiotic administration within 60 minutes before the skin incision. First line antibiotic. Both Royal College and American College recommend cefazolin 1 or 2 gram intravenous, and for women with a body mass index equal or more than 30, a higher dose of 3 gram intravenous is recommended. But WHO recommends only cefazolin 2 gram intravenous. Alternative to cefazolin, both Royal College and American College recommend clindamycin 900 mg intravenous plus gentamicin 5 mg per kg IV, and for extended coverage, azithromycin 500 mg IV in labor or cases with ruptured membrane. But WHO recommend for external coverage. Azithromycin is not universally recommended but may be considered in high-risk cases. And for post-operative antibiotic, all of them not recommended. Post-operative antibiotic if pre-operative prophylaxis is sufficient. Special consideration for Royal College and American College. Higher dose of cefazolin for higher body mass index and use of azithromycin for specific high-risk scenarios. But for WHO focuses on alternative when cefazoline is not available and emphasizes adaptation based on local resistance patterns. Summary of differences between American College, Royal College, and WHO. Dosage of cefazoline. WHO recommends a standard 2-gram dose, whereas American College and Royal College provide dose adjustments based on body mass index. Use of azithromycin. American College and Royal College include azithromycin for extended coverage in specific high-risk cases, while WHO does not universally recommend it. WHO emphasizes adaptation based on local resistance pattern and availability, while American College and Royal College provide more standardized recommendations. When cefazoline is unavailable, WHO provides detailed recommendations on alternatives antibiotics for prophylaxis, including cesarean sections. First, third-generation cephalosporins like ceftriaxone or cefotaxime. Ceftriaxone dosage typically 1 to 2 gram IV. Ceftriaxone is a broad-spectrum cephalosporin effective against many gram-positive and gram-negative bacteria. Its alternative when cefazoline is not available, offering similar coverage for common pathogens involving in surgical site infection. Cefotaxime generally 1 or 2 grams IV. Cefotaxime is another third-generation cephalosporin with a broad spectrum of activity. It can be used similarly to ceftriaxone for prophylaxis when cefazoline is unavailable. Combination therapy for severe penicillin allergy. Clindamycin dose 900 mg IV. Clindamycin is an alternative for patients with severe penicillin or cephalosporin allergy. It's effective against gram-positive cocci including Staphylococcus aureus or Streptococcus species. Gentamicin 5 mg per kg IV. Gentamicin is an aminoglycoside used to cover gram-negative bacteria. It's combined with clindamycin to provide broader coverage, especially in cases of severe allergic reactions to beta-lactams. The third alternative is alternative beta-lactams, which is less common, like ampicillin. Typically 2 gram IV, ampicillin is a penicillin-type antibiotic that can be used in combination with gentamicin. It provides coverage against some gram-positive and gram-negative bacteria, but is less preferred compared to cephalosporins and clindamycins. General considerations. Timing for alternative antibiotic. Ensure that alternative antibiotics are administered within 60 minutes before the incision, similar to cefazoline, to achieve effective prophylactic levels. And post-operative antibiotics. WHO advises against routine post-operative antibiotics if adequate pre-operative prophylaxis has been administered. Local protocols. Always consult local guidelines and protocols. Our recommendation may vary based on local antibiotic resistance pattern and availability. I hope this helps. Please don't forget to like and share.